Okay. Hello and good morning, and a big welcome to the third and the final week of the sixth Emergency Medicine Seminar Series. My name is Dr. Wu, and one of the medical officer in the Department of Emergency Medicine, Hospital UKM in Malaysia. I'm proudly joined today by three renowned speakers from Malaysia, Indonesia, and Australia, with a team of environmental and wilderness medicine. So I will quickly run through today's itinerary. Due to some technical error, we will be starting off with Dr. Mulyo Sugiarto from Indonesia, discussing on heat stroke, followed by Dr. Muhamad from Malaysia. We'll be speaking on major trauma in wilderness setting. And lastly, Dr. Limgenco from Australia, addressing Outback medicine. Again, we will be having a Q&A session right after the last speaker, so please post your question in the Q&A box and we will answer them during the session. After that, we will have a Kahoot quiz season with amazing prizes waiting to be won before concluding today's seminar. So we will start with a few housekeeping announcements before we begin. So kindly post your question in the Q&A sessions, and questions will be answered in the forum after all the presentation. The feedback form will be available at the end of the webinar and will remain open until 3 p.m. today. Please fill in and submit the feedback form to receive your e-certificates and claim your CBD points. Okay, the Kahoot winner can message Dr. Winnie for the price information. Okay, without further ado, let me introduce our first speaker for today. Okay, our first speaker is Dr. Mulyo Sugiarto from Indonesia. He is currently serving as an officer in Indonesian Navy Hospital. He graduated with a military background and completed his postgraduate training in emergency medicine at the University of Brawijaya. Okay, Dr. Mulyo Sugiarto, the mic is yours.
Good morning, everybody. Thank you for the time. You're joining today to seminar on the important topics. It's true. As the weather gets hotter, we will need to be aware of the dangers of the extreme heat and causes to our bodies. And hot stroke is one of the most serious conditions that can result from this. When that happens, our body temperature can rise quickly and go above 40 degrees Celsius. It can lead to be serious health problems. Heat stroke is not about the feeling of heat. It's medical emergency. If someone does get help quickly, it can cause the damage of the brain, heart, kidney, and the muscle. In several cases, it can even be a life-threatening. During the seminar, we will talk about this case of the stroke. Stroke always is most rise like the young children, people working on the military, they have high risk to be the heat stroke. How do we recognize the warning sign of the heat stroke, such as confusions, dizziness, and hot and dry skin? The simple step we can all take this prevent this heat stroke, like drinking plenty of the waters, stay in the sets, wearing like the clothing. What to do if you're someone else shows a symptom of stroke? You will also hear from this health professional who will explain what to do in emergency and how to stay safe during very hot days. By the way, at the end of the seminar, we shall feel confidence as knowing how to protect yourself and your loved ones from heat stroke and how to act quickly on someone changes. I hope you find today's session helpful to get helpful and information. Okay, and let's go we together to stay safe during the hot winters and spread awareness about the dangers of the storm. Thank you for your being here. Let's go. We start about this presentation. Presentation, maybe I can to say in bahasa Indonesia. It's make me confidence. I hope no problem if I say in bahasa Indonesia. In the case scenario, pasien usia namanya Mr. D, usia 24 tahun, tanggal pemeriksaan tanggal Mei 2024, local time jam 12.25 siang. Story taking, ceritanya pasien ini dibawa ke rumah sakit kami, ke emergency department jam 12.25. Pasien ini adalah rujukan atau reference from hospital type C dari tipe rumah sakit tipe C. Kalau di Indonesia rank of hospital, jadi tingkat hospital mulai dari yang paling bawah D, and then tipe C and tipe B, and the top ranking is tipe A. Jadi top rankingnya adalah rumah sakit tipe A. Kebetulan rumah sakit Central Naval Hospital adalah rumah sakit tipe A. Jadi ceritanya pada jam 9.25 pasien ini dibawa dari training area ke rumah sakit tipe C yang dekat dengan area training. Dia datang dengan seizure and tonic-clonic seizure. Ketika dia melakukan aktivitas exercise cross country. Cross country kalau di militer adalah campuran renang, lari dengan membawa senjata. Jadi setelah selama exercise cross country, tiba-tiba pasien ini tidak sadar, kejang-kejang, kemudian lanjut tidak sadar. Pada pemeriksaan fisik yang didapat adalah tensinya untuk sistolnya 92/48 dengan diastol 48, dengan heart rate 122, dengan respirasi rate 30-40, dengan oksigen masker saturasinya 98, dan temperaturnya kurang lebih 40 derajat Celcius. GCS-nya pasien itu untuk eye, buka matanya 1, perbalannya 1, motoriknya 1. Ya. Kemudian dilakukan resusitasi kurang lebih 4 kol kristaloid. GCS-nya jadi meningkat untuk eye-nya jadi 2, perbalannya 2, motoriknya jadi 2. Pemeriksaan kadar gula darah acak didapat pasien ini 92. Oke. Di hospital type C before to my AD. Jadi di rumah sakit sebelumnya, rumah sakit tipe C, pasien ini dipasang akses double lines, kemudian diberi resusitasi kristaloid kurang lebih 4 liter atau 2000 mili. Kemudian diberikan omeprazol, paracetamol, phenytoin, citicoline, dan juga diberikan furosemide. Jam 12.25 nyampe di rumah sakit kami dengan tensi 94/30, sistol 94, diastol 30, heart rate-nya 160 dengan gambaran sinus tachycardia dengan respirasi rate-nya kurang lebih 60. Nanti di videonya di belakang kita bisa lihat ya. Jadi SpO2-nya pasien ini 100% dengan simple max. GCS-nya increase yang semula 222 naik untuk respon to I 3, untuk verbalnya masih 1, motoriknya juga masih 1. Temnya tinggi banget, tinggi sekali, kurang lebih 41 derajat Celcius. Untuk urin outputnya kurang lebih 100 cc, dan blood sugarnya kurang lebih 85. Kemudian planningnya adalah konsul ke kami, konsul speciation. Planningnya adalah di tindakan intubasi, kemudian pemberian metamisol dan suprapat, kemudian pemberian ice cooling. Waktu di kami tensinya 112, sistolnya 112 dengan diastol 64, dengan heart rate 168, gambaran sinus tachycardia. Untuk respiratory rate-nya awalnya 70, lama-lama turun pasien respirator. Untuk SpO2-nya masih 100%. GCS-nya juga mulai naik. I-nya 2, verbalnya 2, motoriknya 5 ya. Untuk temnya tetap tinggi, 41 derajat Celcius. Kemudian dilakukan intubasi, kemudian lanjut dipasang ventilator dengan mode BCMV. Ya. Untuk pos intubasi dilakukan sedasi dengan neodek rangkulim. Ya. Dia masuk metamisol, suprapat, lakukan ice cooling, kemudian dipindah ke ICU, konsul internal dan konsul anestesi. Dari internal dilanjutkan rehidrasi 1000 mili per 2 jam dengan sodium bikarbonat. Kemudian dimasukkan omeprazol, ceftriaxone, dan pemeriksaan darah, juga monitoring dari balance cairan. Untuk hasil labnya kita ketahui bahwa leukositnya meningkat, terjadi peningkatan juga fungsi hati di sini. Ya, kita lihat juga fungsi ginjalnya naik. Untuk analisa gas darahnya kita lihat pasien adalah terjadi ventilasi. Untuk toraknya hasil foto X-ray-nya dalam batas normal ya. Kemudian di progress treatmentnya pada 9 Mei di ICU jam 9 pagi tensinya turun. Ini dilakukan support norepinephrine dan ributamin. Untuk time-nya sudah turun jadi 36,8 ya. Untuk GCS-nya sudah mulai naik, increase, open eye spontan, dan to intubate, motoriknya ini bisa diperintah, skornya 6, SpO2-nya 100% on venti. Juga dipasang CVP access. Pada 10 Mei pagi, pasiennya tensinya tambah turun dan sudah tersupport juga norepinephrine, ributamin, BCS-nya juga tetap bagus, saturasi juga bagus, time-nya juga bagus. Pada 10 Mei jam 2 siang ini tensinya tambah turun ya, tambah turun, GCS-nya juga tambah turun, oke, dan saturasinya masih bagus. Jam 7 malam pasiennya tambah turun, tensinya juga, GCS-nya juga tambah turun, yang awalnya 2x2 jadi 1x1. Dari catatan urin outputnya mulai jam 5 pagi sampai jam 7 sore ini tidak ada, ya kosong. Nah, kemudian advis dari teman sejawat anestesi dikasih loading cairan kristaloid 2000 mili dan koloid 500 mili. Ya. Jam 8 malam 20 pasiennya bradikard. Ya, adrennya cuma 60, tensinya tidak terukur, SpO2-nya juga tidak terukur. Jam 8.21 pasiennya asistul, langsung start CPR sesuai dengan protokol guideline. Ya. Jam 8.45 pasiennya ROSC. Ya. Kemudian disupport dengan norepinefrin, dosisnya ditingkatkan, dobutamin juga dosisnya ditingkatkan. Tapi pada jam 8.47 pasiennya arrest lagi, ya dilakukan start CPR, epinefrin. Jam 8.51 malam, pasiennya dinyatakan meninggal. Jadi kausa mortisnya adalah multi organ dysfunction. Ya. Ini diskusi tentang cuaca di Surabaya pada saat kejadian. Jadi jam 7 pagi itu kalau kita lihat kelembapannya sangat tinggi sekali, yaitu 90 derajat. Kecepatan angin yang sangat rendah. Ini sangat potensi sekali untuk terjadinya heat stroke karena dengan kelembapan yang tinggi, kecepatan angin yang rendah membuat kondisi kan sangat panas sekali. Ini kita lihat kondisi pasiennya. Ya. Awalnya ini respiratornya adalah 70 waktu datang pertama kali. Ini semakin turun. Ya, kita lihat pasien napasnya semakin turun. Ya. Dan heart rate-nya juga mulai naik. Ya. Ya, ini setelah kita intubasi pasiennya, ya, kita kasih cooling, ya, di lipatan-lipatannya. Di setting ventilatornya kita pakai mode VCM. Kita lanjut ke tentang heat stroke adalah kondisi di mana your body is suffocating, di mana dia terlalu lama terekspos karena physical exercise di dalam temperatur yang tinggi. Ya. Efek serius dari terlalu lama dari exposure ini akan mengakibatkan diawali pertama head injury. Berlanjut, kalau itu semakin memberat akan menjadi stroke. Kapan ini terjadi? Bila ini temperatur body kita melebihi dari ini, maka akan terjadi. Dimulai dari heat injury, heat stroke. Ya. Ini biasanya kondisi-kondisi terjadi pada saat bulan-bulan summer, ya, bulan-bulan panas, cuaca panas. Karena itu kalau kita lihat di ramalan cuaca atau di badan meteorologi, kita lihat pada bulan-bulan itu adalah bulan-bulan yang bulan-bulan summer, ya. Heat stroke ini harus segera dilakukan tindakan emergensi, ya. Kalau ini tidak cepat, ya, tidak cepat, ini akan segera merusak dari otak, hati, ginjal, dan muscle, ya, muscle. Ini terjadi bila perburukan ini terjadi bila di awal tadi treatmentnya delay-nya atau treatmentnya tidak tepat, ya. Sehingga efeknya apa? Nanti akan meningkatkan resiko dari komplikasi yang akhirnya ujung-ujungnya akan menjadi meninggal pasien, ya. Pada perubahan yang sangat ekstrim pada suhu tubuh yang lebih dari 40 derajat Celcius. Pada pasien kita tadi, ya, di awal kita lihat pada tempnya lebih dari 40, bahkan mencapai 42 derajat. Ini akan menyebabkan multi organ dysfunction, ya. Yang pertama ditandai dengan neurologic dysfunction. Ini adalah tanda flu dari heat stroke, ya. Kemudian akan terjadi kompensasi dari splenic vasokonstriksi yang akan menyebabkan intracranial pressure-nya meningkat, kemudian kombinasi dengan MAP yang rendah, ini atau tentunya akan cerebral blood flow di otak akan turun sehingga akan menyebabkan central nervous system dysfunction, ya. Akan ditandai dengan penurunan kesadaran atau sampai jadi koma, ya. Stroke juga akan mempengaruhi dari juga mempengaruhi bergantung juga dari cardiovascular system, ya. Ini juga akan nanti mempengaruhi dari sistem sirkulasi, ya. Sistem sirkulasi yang mengakibatkan tensinya turun, kemudian juga akan terjadi kerusakan di hepat, ya. Stroke-nya berlanjut jadi yang lebih parah. Ini gambarannya dengan kita melihat temperatur yang sangat tinggi, kemudian akan ditandai dengan mulai dysfunction dari ya delirium, tidak bisa menyebutkan nama, terakhir sampai terjadi koma atau kejang-kejang atau cuma delirium saja, ya. Pada kondisi kulit ini yang khas pada pasien-pasien stroke adalah hot skin, ya. Atau kadang-kadang ya basah seperti pada pasien saya itu basah kering, ya. Juga akan terjadi elevasi pada pemeriksaan hepatit transaminase. Ini adalah gambaran secara klasik stroke, ada yang secara klasik stroke yang tanpa exercise dengan yang exercise, ya. Ini biasanya kalau yang exercise adalah pada pasien-pasien militeri, atletik, ya. Kalau yang klasik ini yang sering misalkan pada jamaah haji kita, ya. Jamaah haji kita ini kan dipengaruhi oleh juga cuaca, kondisi tubuh yang bersangkutan, ya. Dari sekian ini nanti akan mengakibatkan dengan tem yang sangat tinggi juga akan terjadi respon tubuh, terjadi namanya systemic inflammatory response, yang dia akan mengeluarkan sitokin juga akan mempengaruhi koagulopati, sehingga terakhir dari sekian ini respon ini akan terjadi. Yang terakhir ada DIC proses, ya. Kalau sudah terjadi DIC proses, tentunya yang terakhir adalah multi organ dysfunction atau multi organ failure. Ini secara garis besar itu terjadi thermal injury, jadi microvascular thrombosis, dan jadi konsumtif koagulopati di sini, ya. Jadi blood vessel occlusion, kemudian terakhir nanti terjadi koagulopati, ya. Di koagulopati terakhir akan menjadi multi organ dysfunction. Ini bila terjadi stres, tentunya pertama adalah central blood flow-nya akan turun, lama-lama akan terjadi brain damage, ya. Ya, berlanjut vascular damage, and then coagulopathy, dan terjadi multi organ dysfunction. Sini nanti kalau sudah terjadi ini akan skin blood flow-nya juga akan turun, meningkat, kemudian akan terjadi peningkatan dari permeabilitas membran, ya. Kemudian jadi imun sistem yang akan terakhir, ya, akan terjadi SIRS. SIRS ini juga nanti akan jadi koagulopati. Di sini sistem koagulopati terakhir akan menjadi multi organ dysfunction. Untuk tindakan prehospitalnya tentunya yang pertama adalah pasien harus segera dikeluarkan dari tempat yang panas, ya. Tempat dia latihan yang panas, kita bawa pasien ke tempat yang teduh, yang nyaman, kemudian kita cek gulanya, kemudian kita lakukan start cooling, ya. Bisa pakai ice atau cooling blanket, bisa jadi pakai selimut yang udah dingin, ya. Atau kita kasih spray dengan air pasiennya. Ya, kalau ada in airflow, kasih kipas angin kalau ini. Kipas angin juga. Kemudian segera kita lakukan rehidrasi pasiennya 1 sampai 2 liter. Bila ini terjadi hipotensi pada pasien yang tadi ditayangkan, kita lihat pada tensinya turun dan sudah dilakukan di lapangan, dilakukan rehidrasi kurang lebih 2 liter. Kemudian di emergency department, apa yang kita lakukan pertama, tentunya kita lakukan initial resuscitation. Kemudian kita lakukan cooling techniques, bisa pakai blanket, bisa pakai es yang ditempatkan di lipatan mungkin lipatan paha atau lipatan tangan. Ya. Targetnya yang kita ingin capai, jadi tidak temnya tidak terlalu turun secara ekstrim ya, 39 aja ya. Untuk apa? Untuk menghindari terjadinya hipotermia sangat ekstrim. Kita terlalu hipotermia juga efeknya juga tidak akan bagus sih. Oke. Tetap apa yang kita lakukan pertama adalah prinsipnya airway, kita amankan airway, breathing, dan circulation. Itu adalah prioritas. Ya, kemudian kita uh, intravenous lines kita pasang, kemudian tetap kita monitor oksigennya ya. Kemudian kalau ada ketidaksesuaian antara klinis dengan hasil temperatur, ya kita bisa melakukan confirm dengan temperatur rektal karena bisa saja alat kita itu belum dikalibrasi sehingga kondisinya kurang. Kemudian kita cek darah, elektrolit, kemudian kreatinin, fungsi ginjal, kemudian fungsi hati, ya, lactic profile, blood sugar, cardiac enzyme, serum laktat, dan analisa gas darah. Yang penting adalah prinsipnya pasien ini harus segera di cooling. Mau pakai evaporasi, teknik, bisa menggunakan pakai fans atau kipas angin kalau bahasa Indonesia. Atau bukan pakai skin whiting, bisa pakai selimut yang CS, es blanket, atau kita guyur bersangkutan dengan air es. Ini di mana letaknya yang paling adalah di lipatan-lipatan di aksila, ya, bisa juga menggunakan konflik. Biasanya pasien-pasien yang militer itu di rumah sakit apalagi di Marine Hospital itu ada konflik. Kemudian bisa juga dilakukan rektal lavase, gastric lavase, tapi ini jarang dilakukan. Yang di IGD yang sering dilakukan di emergency department yang bisa dilakukan adalah ya sama ini. Kalau yang selama saya on duty, saya tidak pernah melakukan. Ya, yang sering kita lakukan adalah ini sama. Ini juga secara garis besar kalau kita menghadapi heat illness ya. Jadi ini adalah sign and symptom ya. Pertama kita lihat temnya berapa. Temnya tinggi atau ya. Kalau temnya tinggi apa yang kan? Tentunya kita berpikiran yang pertama adakah dia exercise atau kondisi-kondisi tidak exercise seperti yang ini slide yang di depan ya. Kita harus juga memikirkan alternatif diagnos ya selain stroke, mungkin hipogliksemia, mungkin seizure ya itu ya. Kemudian kalau ini ada temnya tinggi banget, tentunya yang harus kita lakukan tetap kita mengutamakan airway breathing circulation. Ya. Ya, kita lakukan segera. Itu sudah ada jelas kondisinya. Ya. Misalnya pada pasien ini kan jelas ya exercise kita lakukan segera. Kemudian kita lakukan segera ya lakukan cooling immersion. Ya. Kemudian jangan lupa kalau kita di di lapangan di area exercise tadi initial intravenous fluid yang sebisa mungkin kita lakukan itu yang disarankan adalah kita kasih 2 liter cairan kristal. Kemudian segera kita rencanakan untuk transport ke rumah sakit. Dalam hal ini sudah benar apa yang dilakukan dari petugas kesehatan yang ada di daerah lapangan tadi. Dia sudah melakukan resusitasi, dikasih 2 liter, kemudian dia transport ke rumah sakit yang terdekat dari area situ. Kebetulan area yang terdekat dari rumah sakit itu adalah rumah sakit di Besi. Jadi dia lakukan di situ, kemudian dari rumah sakit di Besi ditransfer ke rumah sakit itu. Ini ke rumah sakit. Pada pasien-pasien yang terkait kita harus juga memikirkan kemungkinan yang lain selain stroke. Dia adalah heat exhaustion, heat stroke atau heat cramp. Ya. Untuk yang bukan stroke terapinya tentunya simple, dia harus pakai bisa dikasih oral hidrasi kalau dia GJS-nya full all, jadi sadar penuh, tidak ada gangguan nervous system, dia bisa bicara, kita bisa ya. Kemudian ya, kita segera bawa pasiennya ke tempat yang tentunya ke tempat yang lebih tidak seperti yang tempatnya dia exercise tadi. Kita bawa ke tempat yang lebih dingin ya. Kemudian kita kasih food, kita kasih makan kalau dia kondisinya bagus ya. Kemudian kita observasi eh, simptomnya dan kita observasi hasil outcome kita yang kita berikan. Kalau terjadi perburukan gimana? Kalau terjadi perburukan, setelah kita lakukan agresif cooling, ya, agresif cooling, kemudian kita cari diagnosa yang mungkin. Kalau itu backgroundnya exercise yang mendekati adalah stroke, ya. Kemudian kita rencanakan transportnya, ya. Kita mau menggunakan ambulan tipe apa? Apakah cukup ambulan transport? Apakah cukup ambulan emergency? Ini tergantung dari klinis dari pasien. Oke, ya, ini adalah illness treatment ya. Kalau stroke, ini kalau sudah terjadi ya, stroke, ini tentunya yang pertama kita lakukan adalah remove from the heat source. Jadi kita bawa pasiennya ke tempat yang lebih dingin ya, yang lebih nyaman. Kemudian kita lakukan terapi suportif. Konsepnya adalah airway breathing dan circulation. Kemudian segera kita lakukan cool water immersion, kemudian kita lakukan rehidrasi, jadi akses intravena, kalau bisa double line, kemudian rencanakan evakuasi. Evakuasinya tergantung dari klinis pasien. Kalau klinis pasiennya yang membutuhkan misalkan emergensi, ya dia harus pakai emergensi. Ya. Tentunya akan beda dengan ambulan yang cuma transport. Ini mengingatkan kembali apa yang tadi sudah saya sampaikan di depan. Ini adalah shortcut-nya ya. Kalau kita menghadapi pasien terkait dengan panas, apa yang kita pikirkan? Yang pertama, kita tetap konsepnya airway breathing circulation. Kemudian vital sign, monitor, brain catheter output, ya kita lihat temnya berapa, temnya kurang dari 40 atau kalau lebih. Yang kalau ada exercise itu lebih mudah. Yang susah itu kan yang tidak ada exercise. Ya. Kalau ada exercise mudah. Kalau begitu lebih dari ini ada gangguan neurological system, ini pasti stroke. Terapinya tetap airway breathing circulation. Ya. Segera rapid cooling, kemudian pasang CPAP, kita lihat urine output. Penting initial treatmentnya adalah steroid kualitasnya 2 mili per kilogram per hours. Kalau dia terjadi seizure, kita bisa kasih benzodiazepine atau tidak sedasi. Jangan lupa ada pemeriksaan. Ya, kalau sudah terjadi namanya koagulopati, pemeriksaan soal hemostasi darah diperlukan pada kondisi. Untuk yang temnya kurang dari 40, tidak ada neurologis simptom, ada exercise, ya kita tidak bisa mengatakan ini adalah stroke. Kita bisa mengatakan ini adalah heat house. Itu terapinya adalah istirahat, pendinginan, kemudian IV access. Bisa oral, bisa pakai IV lagi, tergantung dari klinis pasien. Pasiennya bagus, BCS-nya bagus, kita bisa melakukan dengan oral. Ya. Jika tidak ada perkembangan dari sini, bisa saja ini adalah stroke. Kondisi apakah ini? Misalnya pada orang-orang tua, ini jangan berharap kadang time-nya bisa sampai 40. Tapi tetap dulunya kalau sudah terjadi gini. Jadi ada exercise atau kondisi yang lingkungan yang tanpa exercise, lingkungan tapi panas sekali, misalnya pada kasus kita penyelenggaraan haji tanpa exercise, ya kalau sudah ada ini, jadi ini. Demikian presentasi saya dari webinar ini, semoga bermanfaat kita dan kita semua. Ya. Terima kasih, matur nuwun, thank you.
All right, thank you, Dr. We'll go on to our next speaker, Dr. Muhammad Naim. He's a senior registrar in the Emergency and Trauma Department at Hospital Lahad Datu, Malaysia. He has a special interest in wilderness medicine and clinical toxicology and currently serves as the Vice President of the Wilderness Medicine Special Interest Group. He also has authored multiple books and journal publication. Okay, Dr. Naim, the mic is yours.
Good morning. Thank you to the organizing committee for inviting me for the EMSS 2024. Thank you for the kind introduction. I'm Dr. Muhammad Naim. So today I will be discussing on this very interesting topic, the major trauma in the wilderness setting. So I have 40 minutes to discuss on this topic, so please bear with me. So basically today I will discuss about on few things. First of all, I just would like to share stories about how patients survive with major trauma in the wilderness setting. And next on, we will look into the introduction on the wilderness medicine and trauma. And of course, I will be discussing a bit on the prolonged field care. And finally, discuss about the trauma-related injuries in the wilderness setting and what are the special things that make the management different as compared to the one that we are doing in the urban setting. Right. The slide actually belongs to a friend of mine who is aware, Dr. Rupan. He worked with some elephant relocation project in the Cambodia. So last few years, he was in one of his missions. It was about 7:30 in the morning at that time when they encountered few elephants unfortunately, he was trampled by the elephants, who got very angry at that time. Luckily, the crew members are able to scare off the elephants, and they tried to rescue Dr. Rupan. As you can see in the pictures, Dr. Rupan was actually sandwiched on a motorcycle in a very, very painful moment. He was in agony. He was transported on a motorcycle for about 2 hours before he finally reached an outpost. And from there, he need to take another hours of land transportation using a 4x4 transportation into a local hospital. And being in the local hospital that is small and not equipped, so the only thing that they can do for him at the time is to stabilize his condition by giving fluid, pain management, and blood product transfusion. And it was later he was again transported via the ambulance into the medevac point, in which the journey via the helicopter to the main hospital took few hours. And he arrived at the major hospital around 3:30 in the evening, in which that he was further stabilized with massive transfusion protocol. Luckily, he did not need any operations, although he sustained chest injuries, pelvic injuries, and also abdominal injuries. Dr. Rupan is one of the cases that I would say that it is a miracle that he survived despite of extensive injuries. We need to understand that wilderness medicine is something that is very special because of the elements of austerity, and I would say that the distance for someone to receive a definitive care. There is no standard definition for the wilderness medicine, but the Wilderness Medical Society defines it as a definitive care that is more than 1 hour away. People have been using other terms to describe these things, like the remote area, very remote areas. And this field of medicine, it intersects with any other things like battlefield, austere, and also disaster medicine. Right, back to our topic of discussion, trauma. The U.S. legal system defines trauma as a wound or a condition of the body that caused by the external force. It could be due to anything, animal bites, animal stings, chemicals, and even bacterial infections, but it excludes stress and strain in the definition. If we look at the global statistics, about 5 to 6 million people die because of the trauma every year, and the majority of deaths are caused by the road traffic accidents. Unfortunately, we do not have a comprehensive data regarding trauma death in the wilderness setting. Even at the hospital, we do not have a standard accepted definition of major trauma. Different classifications give different definitions. We have few scores available, like Revised Trauma Score, Apache Score, and etc. But it might not relevant to define major trauma in the wilderness setting. For me, major trauma is any injuries that pose an immediate threat to life or limb with regards to wilderness content. And we need to understand that hemorrhagic hypovolemic traumatic cardiac arrest has the poorest outcome in the wilderness setting. So our aim is definitely to prevent this from happening. Therefore, early intervention is. Luckily, major trauma is not a common thing in the wilderness setting. it only constitutes about 5% of the total trauma-related incident in the wilderness. 95% of the cases are the minor trauma. We have some data from the U.S. National Park. Major trauma occurs at about 1 to 9 per 100,000 of visitors. And the majority of the cases occur while participants took part in the mountain activities and wilderness sports. Interestingly, half of the search and rescue cases involve some trauma and a cost for the search and rescue case. Based on the statistics from the 1992 to 2007, 78,000 individuals involved in 65,000 search and rescue incidents. It ended up with 2,659 fatalities, with the others ill, injured, or safe. We need to understand that 1 in 5 search and rescue result in fatalities, and about 11.2 search and rescue incidents occur each day. In the USA, the major cause of search and rescue activation are the hiking and the boating, and others may include climbing, stock animal riding, canyoneering, mountaineering, vehicles, driving, swimming, snowmobile, biking, and also skiing. Unfortunately, wilderness medicine is an uncharted territory in Malaysia, and we do not have much data on the major trauma in the wilderness setting, except for what has been reported in newspaper or literature, but the amounts are very limited. I have involved in multiple medical standby in the wilderness for the past few years, and I'll encounter some of the trauma, but luckily none of the cases are severe enough. And actually, before any expedition to the wilderness, I always pray that I will not have any casualties actually. Well, I do not want anything just to publish a case report or anecdote. No, but to manage such cases in the wilderness is very difficult. So that is why before going into any expedition, a thorough plan is needed so that we do not fail in the wilderness setting. And in fact, for each expedition, 70% of the planning actually involved at the pre-expedition phase. 20% is during the expeditions and 10% post-expedition. For each mission, we need a good communication, teamwork, and appropriate technologies or gadgets to guarantee our survival in the wilderness setting. As I mentioned before, based on our previous standby, most common causes are mostly just athletic foot, tires, rashes, or soft tissue pain. And rarely we do have cases like high altitude mountain sickness. Last year, I had a chance to participate in the medical standby for the Rainforest Challenge 2023. Serious injuries are not common despite how extreme it sounded. Yes, we do have cases in which the vehicle turned over, we have participants hitting the tree branches or even fall from a certain height. But fortunately, it only resulted in the soft tissue trauma. And the other injuries that commonly occur during the expedition is still the trench foot and also the insect sting. Right. To understand more on the concept of the trauma in the wilderness, I would like to highlight these things to you. The differences between the prolonged field care versus the golden hours of resuscitation. If we look at the scenario, 20-year-old gentleman with no non-medical illness with alert fell from height in 3 different situations. In one situation, the journey is about 15 minutes from a hospital. In another situation, it's about 4 hours from the hospital. And the next scenario is in the battlefield, in which that the extrication time is unknown. People might think that those who stay in urban setting near to hospital will have a better prognosis, but does it really so? Previously, we have been talked on the concept of the trauma death distribution. It was found out that 80% of the deaths occur within the first hours after the incident. Hence, the term golden hours of resuscitation are being coined throughout the literature. This highlights that interventions are needed in order to save the patient. But regardless of what, we need to understand that some of the patients, whether it occurs in the wilderness or the urban setting, we still cannot save them. For example, exogenous hemorrhage that are being failed to be controlled, severe brain injury, or high degree cervical cord injuries are non-treatable regardless of what we do. But we need to understand that in wilderness, sometimes simple injuries that are not being treated properly may also lead to death. In order to survive following injury in the wilderness, we actually need to overcome the basic needs and also treat the existing injuries. But for me, the most determining factor that affect the survival is the rapid evacuation. But of course, most of all in the wilderness, the very first thing that we need to do is to actually to prevent the trauma itself. That is why prior to any expedition to the wilderness, someone really needs to do a well-planned activities. They need to keep their physical fit, and also they need to do what we call as risk management and mitigation strategies to identify certain dangers that might potentially arise during the activities and mitigate them. As I mentioned before, certain injuries that are not being treated can lead to a catastrophic consequences. Hence, it needs to be treated early with the first aid. During the event, if someone suffered from incidents, we need to identify the patient that will deteriorate. And of course, we need to continue observation and prevent the hypotension. As I mentioned before, urgent transport is needed, but sometimes it is not the best scenario. Therefore, in the wilderness, evacuation planning is one of the important things. Right. Sometime in the wilderness, it is very difficult for us to decide whether we want to continue the expedition or to terminate the expedition and go for evacuation. In most of the cases, especially for those who pay for the expedition with certain objectives like conquering the Mount Everest, they have been practiced for years and the fees are very expensive. Sometimes, because of simple injuries, they refuse to stop. This is quite tricky and requires a huge consideration. But a harsh truth is that in the wilderness, we need to understand that we cannot save everybody. Regardless of our effort, patients may still die. As I mentioned earlier, golden hours of resuscitation is not relevant in the wilderness setting. In order to increase the chance of survival, we have this concept called prolonged field care. This concept is actually being introduced by the Army. It refers to a field medical care applied beyond doctrinal planning timelines by the Special Operation Combat, Medic, or higher. This is to decrease the patient mortality and morbidity by utilizing limited resources, and is sustained until the patient arrives at the appropriate level of care. In a tactical combat casualty care, when personnel suffer injuries, the care will be divided into three phases. The care under fire, basically aiming just to stop the bleeding. Then, a proper assessment will be taken once the situation is under control. This will be called tactical field care. And finally, comes the tactical evacuation care to evacuate the injured soldiers into the military hospital care. However, the tactical evacuation might be delayed, and hence the prolonged field care concept was derived. The idea is that not all times we can give the best treatment to the patient. Sometimes we can give what they call it as a minimum treatment, better treatment, and the best treatment. And most of the time, they need to administer the alternative treatment or improvised method when the optimal hospital options are not available. For example, that if you have a patient with bleeding from the amputated proximity, the best treatment would be to stop the bleeding by the best method available, the combat gauze or the quick clot, cap tourniquet, and to spleen it with the vacuum spleen embolyzer. Tranexamic acid should be administered early, as well as giving fluid resuscitation by the IV and blood product using the field transfusion or the freeze-dried plasma. But at most of the time in the wilderness, we are only able to do a minimum care using the improvised bandage, use the piece of cloth, improvised tourniquet, and improvised immobilizer. But if you are prepared enough, you might have the combat gauze, the cap tourniquet, and stem spleen that will give a better care to a patient. To help combat medics treat the injured soldiers, they come out with this mnemonic called the MASH2H3 Pulse L treatment algorithm that include managing the massive hemorrhage, taking control of the airway, respiration, circulation, communications, hypothermia or hypothermia prevention, managing the head injuries, the pain control, starting the antibiotics, treating the wounds, splinting, and also considering the available logistics. However, prolonged field care in the Army concept is not the same with the civilian concept. One of the reasons is that both situations have different demographic profile, physiology, and adaptation. As we know that most Army are young, they are fit and healthy, and before any mission, they already do a screening, the blood groups, as well as screening for any diseases. So in case of any emergency arises, they basically know what to do, and they can even draw a blood from an individual and transfuse to the others. But our general population constitute a wide array of demographic profiles, but some things are still able to be adapted. In our courses, we teach participants on the big jet in the wilderness for the patient assessment system. This is actually similar to any other patient assessment, but with some emphasis on the wilderness situation. Especially, we pay more attention to the scene and dynamic risk assessment, followed with hemorrhagic control and the primary assessment. Another thing that makes this system different than managing the patient in the hospital is a lot of time also needs to be focused during the ongoing assessment and planning for the evacuation. You can scan the QR code if you would like to learn more about this system. Different levels of causes are available and provided by our societies, but this is basically with the aim to empower the responder in the wilderness setting so that we can increase the chance of survival following the injury. In a prolonged field concept, they divided the things into 4 things, which is the ruck, truck, house, and also plane. Ruck is basically anything that you have in your first aid kit that you can use during the emergency. Usually, the supplies will help you to stand within 1 hour period. Truck is much more bigger equipment or medication that we usually keep in the vehicle. But in the wilderness setting, this might be applied even to a yak carrying our medical supplies. The house refers to a temporary base camp, and patient may stay here for more than 4 hours. And finally, the plane refers to evacuation process. And in the wilderness, there is no specific time frame to define these things. Let's move to specific conditions related to major trauma in the wilderness. I would like to go by sharing a case of this 38-year-old gentleman who is a legal immigrant, basically fell from the motorcycle and skidded into the nearby river in one of the remote areas in the Lahad Datu. While trying to evacuate himself, he experienced a heavy biting sensation over his right leg and excruciating pain. Turned out it was a crocodile bite. He was lucky enough that he is able to poke the crocodile eyes and escape the beast. With a broken leg, he ran into the nearby village, in which they helped them apply a tourniquet and immobilize the right limb. Patient was subsequently sent to our department throughout 2.5 hours of journey, and he was lucky that it was just open right tibia. However, not all victims will be lucky. We had a lot of human-wildlife conflict in our place, especially the crocodile attack, the snake bite, jellyfish stings, and sometimes we have the elephant attack, sun bear, and even otter attack, as well as the monitor lizard. Our previous patients are lucky because he only sustained open fractures and not much of blood loss, and appropriate first aid was given, and he managed to arrive to the hospital at times. But in many cases, not all the victims survive. Crocodile is an opportunistic predator. He will basically just wait in the water quietly and attack the victim. The signature mark for the crocodile attack is the death throw. Basically, this will kill the patient. But sometimes they will pull and drown the victim. Crocodiles are unable to chew the body part, and they will disengage and swallow the body part. However, this crocodile attack will usually associated with major bleeding, and based on our experience, if you are able to tackle the bleeding and the injury did not occur at the major vital organs, patient will survive. Of course, once the patient arrives in the hospital, they will need a lot of management, and it involves a very long time, including the rehabilitation. As I mentioned earlier, cardiac arrest following hemorrhagic hypovolemic shock is carrying a worse prognosis in the wilderness setting. Hence, we need to treat any wounds to prevent the complications. In the case of uncontrolled catastrophic hemorrhage, early tourniquet are being advocated. When you're using the tourniquet, you need to be careful not to buy a fake tourniquet as it is being proven not to be effective. I do not intend to discuss detail on the tourniquet because of the short of time, but basically you need to put in at the right place for the right indication. Sometimes you may need double tourniquet to control the bleeding. And in the wilderness, you may need to improvise the tourniquet if you do not have any of it. Patients with trauma may have decreased level of consciousness. Another important aspect that we need to look for is to maintain the patency of the airway. As we know that simple procedures like the head tilt chin lift or the jaw thrust will open the airway. But in the wilderness setting, because of the limited personnel, sometimes it is very difficult for you to do it at a long time. So our fathers of wilderness medicine actually teach us some of tricks that you can apply to maintain the airway potency. As we know that the fallen tongue is one of the significant causes of the airway obstruction, you can actually secure the tongue by anchoring it to the lips using pins, ropes, or even hooks. Certain patients with facial trauma may be beneficial with a simple maneuver, which is the sit upright and lean forward. This will help them to maintain the airway. But if it is not feasible, they might need a surgical airway approach. In the wilderness setting, you may need to perform a bizarre procedure to help with the airway management. You can use whatever tools that you have with you. For example, like using the pocket knife and the platypus tubing to do a cricothyrotomy in order to open the airway. Next, we go to the spine injuries, particularly the C-spine. 2 to 4% of trauma patients have cervical spine injuries. Fortunately, just about 20% of them have the spinal cord injuries. However, the true incidence of spinal cord injuries in the wilderness is unknown, but it is more common in activities like pressurized motorsport activities, tree climbing, mountain climbing, scuba diving, paragliding, and kayaking in the rough water. There are wide spectrum of cervical spine injuries, ranging from just a mild spine pain to a significant spinal cord injury leading to paralysis. In the wilderness, it is very important to do a focused spine assessment to identify those who might need evacuation for imaging and further management. We have multiple tools to aid us, for example, like the Canadian C-spine or the Nexus criteria. In the wilderness, we may also use the combination of Canadian C-spine rule and Nexus through an algorithm created by the Wilderness Medical Associate. Before performing the spine assessment, we need to ask the patient to lie still or even sit with restricted neck movement prior to assessment. If patient is unconscious, you may stabilize the spine before proceeding with the spine assessment. There is mantra that has been taught in the urban pre-hospital care that all trauma patients will need the cervical collar. But this is very controversial in the wilderness medicine. First of all, there is no studies that prove the effectiveness of the cervical spine collar. And in fact, the recommendation of putting the cervical collars are based on the expert consensus as been highlighted in the trauma life support. While it is able to prevent the flexion and extension movement, cervical collar basically is not effective in preventing the lateral movement of the neck. We need to understand that in cervical injuries, what is causing the paralysis is the cervical cord edema. But does the cervical collar actually prevent this process? And it is very hefty to carry the cervical cord in the wilderness setting. Some people may argue that it may be useful during the evacuation or transportation, but the latest guidelines on cervical injuries in the wilderness does not recommend the use of cervical collar. But of course, you need to protect the spine in all your assessment or during the transportation. If you are interested to learn more about this guideline, you can always go to the Wilderness Medical Society website and look for the algorithm to cure the spine injuries. The objective of identifying patients with spinal injuries is to actually identify patients that need evacuation for further imaging and treatment. But it doesn't mean that all patients with cervical injury need to be carried on stretcher. For patients which is awake and ambulatory, self-evacuation is the best way to bring them out from the wilderness. You just need to remind them not to move the neck excessively. For patient who is awake but non-ambulatory, backpack side carry can be used. But patients who are unresponsive or with altered mental status may need litter or stretcher with spinal cord protection using the body vacuum spleen. Patients with cervical or spine injury does not need to be evacuated in supine position, but putting them in the position of comfort will help with the pain and bring more comfort. And of course, you also need to put a lot of padding if you need to carry them out for a long distance, as it will increase comfort and reduce the pain. Next, we go to the breathing problem and chest trauma. It is uncommon in the wilderness setting and can be from simple rib fracture to severe chest injuries involving vascular, cardiac, or lung injuries. Not all the injuries can be treated in the field, but early recognition, stabilization, and rapid transfer is important. You can do things to treat open chest wound, pneumothorax, and hemothorax. Last time, we have been talked about the three-sided occlusive dressing for those with open chest injuries. Based on the latest studies, it has been proved that it is not working. The current recommendation is to use the vented chest seal if available. Apart from that, for patients with suspected pneumothorax, neither decompression may be needed. Based on case report, it is possible to do improvised chest tube drain for decompression of an acute tension pneumothorax in the wilderness. Sometimes, if you do not have the tool and patient is in very severe respiratory distress, you may actually perform the finger thoracostomy to release the pneumothorax and put the vented chest seal. Or you can even use it to remove the hemothorax. Another particular aspect that you need to look for those patients with pneumothorax is during the evacuation, if it involves the evacuation. Usually, evacuation using helicopters is safe at the altitude of 500 feet from sea level. Although theoretically, it may increase in size with each 500-foot increase in altitude. But for a patient who needs to be transported via the commercial flight, the cabin should be pressurized. If the patient is on the positive pressure ventilator, they may need chest decompression and thoracostomy. For a patient with shock in the wilderness, of course, you need to maintain the ABCs, you need to give fluid. Sometimes it is very difficult to give fluid in the wilderness. The best way to give fluid is via the oral mouth, via the oral route. If it is unsuccessful or patient is unconscious, you may need other approach like using the subcutaneous approach or even via a rectal. Since I'm running out of time, I might not be able to finish all the slides. For head injuries, it is not common, but we need to identify the features of serious head injuries. There's nothing much we can do in the wilderness, so the best thing is to evacuate them. Abdominal trauma is another uncommon but tricky situation to be handled. As I mentioned, that serious bleeding will lead to poor prognosis, but sometimes to decide on evacuation is also difficult. If the patient turns to have the wound at the abdomen, sometimes we might do a field exploration. If there is any breach to the fascia or evidence of peritoneal irritation, then patient needs to be evacuated early. Next, for the patient with pelvic injuries, we need to identify those with the stable or unstable pelvic injuries. But you need to understand that if you decided to put a pelvic binder, please also secure the femur and also the foot, because it's usually associated with femur fractures. And finally, you also need to prevent the hypothermia. There is always the myth being spreading around that you cannot get hypothermia in Malaysia, but we need to understand that it still can occur, especially for the patients with trauma who are prone to hypothermia. Right, and the next is you need to consider for evacuation. There's a lot of things that you need to consider, but it is based on the subjective and objective decision. When you deal with emergencies in the wilderness, you need to look at the nature, the injury pattern, the accessible, and any critical organ involvement. For example, like a disease victim may be transported later, and priority should be given to those who are critically ill. Those with the minor ailment may receive the field treatment and continue with the expedition. I think that my time is up. I'm happy to receive questions from the audience. Thank you.
Yep. So we're having our break right now. We resume it at 10:30. Thank you so much. Okay, hello and welcome back. Before we resume our session with our last speaker, just a heads up. If you have any questions for our speakers, you can post them in the Q&A box and we will answer them at the end of the session. Okay. Let me introduce our final speaker, Dr. Henry Limgenco. Dr. Henry is a emergency medicine consultant at Irwin Hospital in Australia, and he is a clinical senior lecturer at the University of Adelaide. He also served as a retrieval consultant with the Royal Flying Doctor Service, demonstrating his dedication to provide critical care in diverse and challenging environments. Dr. Henry, the floor is yours.
Thank you. Good afternoon if you're in my part of the world, and good morning for the rest of you, I believe. So, thank you for the invitation and for allowing me to speak today. Many thanks to the organizers. So, I'm speaking about medicine in the Outback. It's very much similar to Dr. Naim's talk in the sense that we're working in a wilderness type scenario where austere situations. So for now, okay, and disclosure. So I have nothing to declare. I have no financial relations with regards to this. I do wish to acknowledge the traditional people of Australia and particularly Adelaide, the Kaurna people, where I am, who are the traditional custodians of the lands where we work, live, and play. I also like to take opportunity to pay respects to leaders past and present and emerging who are integral to the communities across Australia. So as a background, Australia is, as you may know, a big country, but to put it in perspective, we're approximately 90% the size of continental US. And we're about the size of Southeast Asia and India combined. So that's how big we are. However, we do not have a lot of people. We're a country with only about 26 million people, and 90% of the people live on 10% of the land. And that 90% of the land is on the coast. So just to give you also perspective of how our population density is, I've thrown up some numbers across and just look for which one interests you. I'm originally from Manila, and we are notoriously the most populated, densely populated city in the world. The numbers in the parentheses on the far right are areas within that city with their peak densities. So although the average in Manila is 46,000, it's as high as 71,000. In Adelaide, where I live at the moment, the peak density is only 2,341 people, with average being 444 per square kilometer. Just to give you an idea of what I work with as a retrievalist, here's a simple case of an MVA rollover. I receive a phone call at 2:30 in the afternoon, where I'm here in Adelaide, from the South Australian Police, and they have attended a high-speed rollover in high-speed MVA in Nundru, which is 30 kilometers east of the nearest roadhouse. So it's a single vehicle rollover. Car was traveling at 110 kilometers, which is the posted speed limit, and the car rolled 4 times. No other vehicles were involved. There were 2 occupants who self-extricated and were ambulatory at the scene. I suspect they called the police themselves. Both of these occupants were complaining of right neck and shoulder pain, and one patient had cuts to the hand and his head. I immediately looked up on the Google Maps on where Nandru is, and I find out that it's more than 900 kilometers from where I am. And like I mentioned, the nearest uh, reminder of civilization from where they were was the roadhouse or the gas station that was 30 kilometers east of them. Okay, so why is that relevant? Because then I have to then uh, put my thinking cap on and decide, okay, I have two patients, how much they weigh. So I had to call back and ask each one. The first one was 90 kilos, 80 kilos, sorry. The other person was 110 kilos. So I have to factor that in. What are their injuries? So do we need to think about C-spine injuries and we need to immobilize them, etc. Where is the nearest airstrip and what's the condition of that? In this scenario, they gave me three options. One was in near Nandru. However, that airstrip has not been maintained, so they don't know what the condition is. The nearest next one was an airstrip that was 100 kilometers away. Sorry, 50 kilometers away, and one was 100 kilometers away. The preferred one was 100 kilometers away, but obviously that in itself creates another layer of complexity. It's 2:30 in the afternoon. There are rules around flying which say that they need to chart a flight path. So even if I activate them at the time of the phone call, which I did, they cannot take off in earlier than 40 minutes or 45 minutes from that because of the process of. So it will mean that they will leave at 3:30, maybe 3:15 to 3:30, and it will take about 2.5 hours to get to them. So we're looking at 5:36. So we're looking at sunset, which becomes more dangerous. Most of the airstrips, these are not airports, these are airstrips, just places to land an aircraft, are dirt and do not have lights. What's the weather? And this is where it became complicated because the weather forecast was there was a storm that was rolling into the area. So we need to work hard and fast so that we could get to them in time. Then you have to think of the equipment that you require, like vac mats. You have two patients, you need two vac mats, etc., etc. How long will it travel? As I mentioned, it's to get there will be takes amount of time. Then you have time at the site, which then means that you have to consider these and then travel time back. What's the weather going to be like? What's the conditions in terms of the strip at the time? Can you actually fly out of that strip at that time? So all of these we have to consider. Who's going to receive the patient, and then we have to factor in crew fatigue. We may be looking at travel times or the time of the job, but the crew has been working before that, so we have to consider that as well. So these are kind of situations that we have to think about. Who is also at the site with this patient, because they're in the middle of nowhere, literally in the middle of nowhere, nobody in sight for miles around. So just to give you an idea of what we're working with, what is the Outback? The Outback is described as remote and desolate areas of Australia. It spans an area of 5.6 million square kilometers. It covers about 70% of the Australian continent, as you can see in the picture, and where approximately 600,000 actually live, work, or play. So density in that area is about 1% for 10 square kilometers. Just to show you on the map, this is where I am and this is where they are. Okay, so like I mentioned, why do people live in the Outback, or why are there people in the Outback? Because they live there, or they work there, or they play there. Okay, so who are these people that live in the Outback? We have the Aboriginal community. So these are the traditional custodians of the land. And then you have station owners or ranch owners and their families. You have boom communities that have gone bust. So what are these communities? These are places that have started up as looking prosperous, that may become a community in the future, but something happened and they've dwindled. But people have remained there in that area, so they've become isolated. And then you have support communities for places like mines. We're a big mining country. We have a lot of activities that occur in the Outback related to mining. We have truck routes both to the mines, but also across Australia. So as the motto among the truck drivers go, without trucks, Australia stops. So we are very much into getting things across Australia through trucks. And then there are people who go out there and to play, and we need people to support them. So people who live in communities that are, let's say, camping sites and recreation sites, or these other areas that they visit. So who work there? Mining is probably the biggest one. Most of them go in and out with what we call fly in, fly out, or FIFO. We have the station hands, or people who work at the station but don't necessarily live there. They're not the owners, or seasonal workers. For example, drovers, who are people that help move cattle around the area. They come in just for when the cattle are ready to be moved. Truckies are what we call truck drivers here, and so other support services like your park rangers or other workers in the area for your power grid and their telecommunications. Okay. So who play there? So our most common enthusiasts are your four-wheel drive and dirt bike track people. Next, you have probably your campers and your bush trail walkers. We have a very strong rodeo mentality or community in Australia. So they go around because it's part of their work and it's how they play as well. And interestingly, these communities invite people to come over by sponsoring music festivals to help their community tourism. So just a quick reminder, we provide universal healthcare in Australia. And why is that relevant? Because we are now required to provide healthcare to everyone, wherever they are. Primary healthcare is funded by the federal government, so they are tasked to provide this healthcare in these remote areas. Specialist services are usually funded by the state governments and not the federal governments. We still have private healthcare funds in Australia, but most of them are because it provides a tax incentive. It lowers your tax if you have private health. It then gives you the ability to select doctors, and you generally have shorter waiting periods. You can choose to have better in-hospital services as part of extras. Often you have to pay a gap, so there's a fund. There is what the fund will cover, but usually the private doctors will ask a bit more on top of that. Okay, so how do we provide healthcare in the Outback? Okay, you need people. So you have doctors and other specialists. You have nurses and other allied health professionals. You need transportation and communication. You need medication and an infrastructure around that. So who are the doctors for rural and remote Australia? They are generally called rural generalists. They are provided with specialty training to meet the demands of working in austere environments. They often have additional skills, so they choose a subspecialty. In these areas could be obstetrics, anesthetics, mental health, and many more. Okay, they work within the community, so they embed themselves within the community so that they can develop sustainable living within the community. They get to know the people, the elders, etc., both local and regional. They get training through either a fellowship pathway to the Royal Australian College of General Practitioners, so their fellowship in rural generalist practice, or they're in the late 90s, a new college was formed called the Australian College of Rural and Remote Medicine, which you graduate to work with the skills in remote Australia to deal with remote Australia. Okay, so with specialist services, so if you have an emergency scenario and you have 24 access to this statewide, the common ones are the chest pain or the ACS, acute coronary syndrome pathways. We have what's called iCarNet, which is our cardiology consult service. They have an on-call 24/7 consultant. They have posters that we put up in all of the clinics in the rural areas, and we have one in our communication center in Port Augusta, wherein basically it shows us a pathway on how to handle or manage chest pain and ACS. We have an acute stroke service through the neurology team at the Royal Adelaide Hospital. Again, we have a 24-hour service. Usually it's run by a registrar or a senior trainee with a consultant backup. They can then do neurologic assessment, usually via video conferencing. We also have an 24-hour obstetric service through what's called the perinatal hotline. It's both a guide to birthing and neonatal care. Sometimes they can help you with complex delivery, but if you need an obstetrician, they can also organize one which is similar to this other surgical emergencies. There's an option to bring the surgeon to the patient to shorten that time for definitive care. For other routine consults, though, there's still a service provided, and they get it through the regional or rural, regional hospital or rural clinics. And then they can also do, that's if they want it face-to-face, but they can also do virtual consults through remote clinics. My wife, who's an obstetrician gynecologist, does face-to-face consult in a regional hospital. Obviously, she can't do, or it's difficult to do virtual consults for gynecologic issues. There is also a thing that has been developed called the remote area nurse, or a RAN. So they have a specialist training program within the nursing. They're usually senior nurses that have done 2 or 3 years already before they become rural area or remote area nurses. The nurses are allowed to work independently in rural and remote locations under the guidance of protocols or via telehealth. So a lot of times I will get calls as the senior doctor on for RFDS, and they will ask us to supervise them in the management of a case locally, either via telephone or via video. They get specialized training in emergency nursing, maternity nursing. They get enhanced clinical assessment still, so they are able to do the physical assessment for you remotely. They get also advanced teaching in a pharmacotherapy, therapeutics, and immunization. They are taught to manage difficult behaviors, not only for the patient, but for their safety. They're also given cultural safety courses to make sure that they do not upset anybody and work within the culturally accepted practice. And they also get a 4-wheel drive course so that they can get to the areas where the patients are or to their clinic safely. So transportation and communication, and this is where the Royal Flying Doctor has provided the biggest input. So it was established in 1928, so we're now 96 years, sorry, by Reverend John Flynn. And it originally started as the Australian Inland Mission as part of the Reverend's job. And he created an aerial medical service to provide medical assistance to the stations in rural and remote areas. So this was the first aeromedical service in the world. In 1929, his friend Alfred Traeger invented the pedal-powered radio, revolutionized communication in the Outback. So basically, they made a box and then pedal-powered radio, and they'll put one in each station that they were servicing, so they could communicate with the base. This was in Queensland. Okay, the service was renamed the Flying Doctor Service in 1942, and was given a royal grant in 1955 by then Queen Elizabeth. It's actually made up of 7 legal entities by region, so that's not one Royal Flying Doctor, but they're all federally integrated, so they all communicate with one another. And now we're just known as RFDS, or the Flying Doctor. So I've just put this up so you can see how Australia has honored RFDS. So this is a picture of Reverend John Flynn on our $20 note. This was the first aircraft that was used by the then Australian Inland Mission. And this at the underneath the plane is the first pedal-powered radio. So they pedal to create energy for the radio that they can then send the communications through. So the RFDS prides itself by providing furthest to the furthest corner the finest care. Okay, so we have, what are the services we provide? So we provide a primary emergency or medical response for accident or illness. So second is we do provide evacuation and medical retrieval. We can also provide non-emergency transport, and pretty much this is a majority of the work that we're doing now. We provide 24-hour, 7-day a week telehealth service. We also provide primary healthcare clinics as deputized by the state and federal government. We do consultations, communication support for rural remote doctors, not just patients, but also we support doctors across Australia. We provide interfacility transfer. We provide education and training as needed. So what happens in the primary healthcare service center? So these are general practitioner services. Basically, nursing, child, and maternal health is looked after. We have a special Aboriginal and Torres Strait Islander focus because that's our majority of the people that are in these outback areas. We also provide a rural women's service. There's a thing that we call here as it's women's business or it's men's business. So I think if you guys can understand, we're in men are ideally supposed to take care of men and women supposed to be taking care of women. We have mental health services as well that we provide. Dental services is a new service that was started in the last 3 years. So, and that's very important because Medicare does not generally cover dental services. We also provide allied health. So we're now providing social work, physiotherapy, among others. So pharmacy therapies as well. So education about medications we also provide. And like I mentioned, we can help them with medical specialists. So referrals to or organizing their consults. So the other cornerstone of how we manage healthcare in the Outback is through the RFDS Medical Chest Program. So the Medical Chest Program was initially started in 1942 to assist those needing medicines or medical supplies in remote areas. It's a standardized first aid kit to help in significant emergencies until help can arrive. It's a lockable steel box containing a wide range of medicines, including antibiotics, epinephrine, midazolam, and morphine. So interesting is here is that even drugs of abuse are part of the box. There are approximately 3,000 medical chests all over Australia, all of them provided by RFDS. The contents are coded to help locating where the drugs are and also to prevent abuse. And the doctors authorizing the medication will then give a code, and this code serves as his signature. It's like I gave a prescription and allows the medical chest owner to then replenish the items. So this is what demonstration chest looks like. It's going to be the same size and its contents that it has. It's in box trays, so you can then tell them what you're looking for. Oh, please go to tray A, drug number so and so. Okay, and then you can tell them how to dispense it. So who's eligible to obtain a medical chest? So there are rules around it. So need to be 80 kilometers from a professional healthcare provider like a hospital or a clinic. There are areas that are exempt because they are seasonally cut off from these hospital or clinics due to bad weather, roads becoming inaccessible. They require to have adequate telecommunication to ensure that they are allowed to use it because they need authority for the restricted items. Okay, so you have one. Now, what are your obligations? You need to ensure that the box remains locked when not in use, that the contents are regularly checked for completeness, and that none of them are expired. Restricted prescription drugs are only to be used under the RFDS doctor's instructions, and medical chests are registered to a location and must not be moved without prior permission. Medical chests are also ascribed to a particular person, so I know that there's a medical chest in the roadhouse. I cannot just walk up to the roadhouse and demand for them to give me the medications that are in the box because they are the property or the responsibility of the person that signed them out or who is in charge of them. So things that often asked, so is the medical chest only for use in emergency? No, it's like I mentioned, it's a first aid kit, but it's a first aid kit with extra stuff in it. Do I need special training to have or to use the chest? No, but they recommend having having undergone a senior first aid course. Can I use a chest for my animals or pets? No. Please speak to your veterinarian. Can I call a GP friend or other doctor to prescribe items from the chest? No, because they won't have the code that's needed to replenish the items in it. They also don't have the codes to be able to use or to know where the stuff in the chest is. Can I buy a medical chest? The medical chest officially is not for sale. It's provided out by a grant from the federal government. There are certain areas like the mining sites where they can request for a medical chest, but they then pay the federal government for it. So individuals cannot buy a medical chest. What should I do if the drugs go missing or are stolen? Needs to be reported to police and it becomes a police matter. So dispensing the drugs inappropriately means that you get reported to the police. Okay, what about specialized drugs, treatments, and blood products? So some retrieval services keep massive transfusion packs within their service. Some antidotes are also kept on the base. Other less common treatments are kept with major referral centers, either tertiary or secondary hospitals. And these are then collected upon approval of the coordinating retrievalist or medical specialist to be taken with them on transport with the retrieval team to the patient. So we do not keep, for example, antivenin with us for snake bites because they are hard to keep. Plus, use is dangerous if inappropriate. So the bush clinic. The bush clinic is what we call our primary health clinic that comes and goes. So these in most areas, RFDS is then has been deputized to provide the primary care to the remote clinic, and that's what we call the remote areas, which we call the bush clinic. It's an outreach clinic and it's set up for a particular region once or twice a month, depending on the need. For some people, it's very similar. If you can understand, it's like having a free clinic in a rural area, but this is our regular clinic. It's an opportunity to deliver regular prescriptions as well. So it's somebody who is just maintaining their health. For example, a diabetic, they don't need to be seen every month or seen every 6 months, but they need their medications every month. So it's an opportunity for the team to come down and distribute their medications. This can include other seasonal services such as immunization, dental, or allied health services. Occasionally, patients are identified while having the bush clinic who need urgent specialist care. So initial care may be commenced under the guidance of a specialist remotely, but sometimes these patients need to be retrieved, but they need to be retrieved separately because the plane has already been allocated its role for the day, meaning it's usually full when it leaves the base and will not be able to take an extra patient on the way back. So what other infrastructures are required? Aside from the roads, primary clinics are basically built through collaboration with the local government and federal government. I should also add that within the Aboriginal communities, they often create what's called Aboriginal corporations that generate funds that help build infrastructure as well, like the clinics. The airstrips, these are usually just daytime and dry weather use only. They are federally owned and built, but they are maintained by the local community. The local community does this because they know that that's their lifeline to RFDS and the rest of healthcare. Patient transfer facilities. So RFDS has invested heavily into creating patient transfer facilities. These are hubs wherein the plane and the patients and the local community meet so that it's a sheltered facility that allows transfer in a safe environment from the weather. So when it's hot, you don't get sunburned or dry out or heat stroke. And if it's raining, then you don't get wet and then suffer hypothermia. So very important, how is this all funded? You might be thinking. So primarily it's federally funded through Medicare or similar. 80 to 90% of funding of RFDS, for example, is through this means. There is local government funding, but that's more at the ground level, grassroots level. As I mentioned, Aboriginal corporations that are able to generate funds among themselves. So they create a business that allows their local community to improve their facilities. This is probably where a lot of the funding that is, so I said 80 to 90% of their operational funding is through the government. Donations and grants cover most of the remaining. Bequeathments are a big one. A lot of people before they or in their will say that they want their house to be donated to RFDS, for example. And the last one is a fundraising event. Every year, the RFDS has a fundraiser to try to generate for projects. For example, they want to build a new patient transfer facility in a particular area, then they will do a fundraising for that. So RFDS today, we have 81 dedicated air medical platforms. So that's more airplanes than some airlines. We have 77 turboprops, we have 3 jets, and we have 1 helicopter. We do also have standard road ambulances, and we also have 4-wheel drive road ambulances. Our biggest plane, or the most number of planes we have at the moment, is of the PC-12 kind. Pilatus PC-12s were specifically designed in coordination with RFDS to be an all-weather plane to be able to land on their airstrips. So we are one of their major customers. Also, we've done the PC-24, which is a jet version for long haul scenarios. The PC-12 can put 2 patients lying flat. The PC-24 can do 3 patients lying flat. The range of each, the PC-12 is about 2,800 kilometers. The PC-24 is 3,300 kilometers. This is our standard road ambulance and our 4-wheel drive ambulance. Okay, so what is the future of remote emergency care? A project was started a couple of years ago, and we developed Williams Creek Virtual Emergency Care Clinic. It's a standalone clinic literally in the middle of nowhere with a community that's about 30 people strong, but not enough to put up their own clinic. Okay, they're a major crossroad of a lot of trucking. So that's one, and I'll show you something about that next. But we are also working for the improving acute care of stroke. So we are working on, or my boss is working on, transportable head scanners. So they've, by presenting a challenge to industry, they wanted to create a means by which care can be provided earlier for patients with stroke. It's still in the early phases. However, the first one to come off the block is the EM View. So the EM View is a microwave scanner for the head. It's not designed really to say whether you have a stroke per se, but its initial stages is to determine whether you have a bleed or not a bleed. So then you can then consider whether you can start with aspirin, for example, or maybe down the road when it becomes more definitive, whether you can even start thrombolysis. Again, it's an early phase. At the moment, the other contender is whether we can fit a CT scanner onto our aircraft. So that is one of what we're working on. So the Williams Creek Virtual Facility is an emergency care facility that provides access 24/7 via key code. There is nobody in the center. It is a walk-in clinic in the middle of nowhere. It connects you to an on-duty rural generalist supported by the on-call critical care specialist. The history is taken through video call. Patient and or carer can be guided through taking the vital signs and doing the physical exam. There is an ECG machine there that they can walk you through on how to set it up. They can do a urinalysis. They can do finger prick blood tests for, let's say, blood sugar or even troponin. And medications are sourced through the medical chest, as we mentioned earlier. And there are 2 medical chests in Williams Creek. So two individuals have the medical chest. So the Williams Creek Virtual Emergency was inaugurated just this year and has since served 25 patients. So it's roughly about 1 patient a week. 1 patient received treatment and did not require retrieval. So that was one of the best outcomes. The rest were retrieved. So 24 were retrieved. There were 2 critically ill patients. One was an anaphylaxis and one was a septic patient who received emergency management with the help of the Williams Creek town folk and video support while waiting for the arrival of the retrieval team. So they were able to provide care much, much earlier. So what happens is you walk into the clinic, you buzz in, they get you in the door, you get a link to a telehealth with a doctor, a doctor in Adelaide. You're guided through doing the tests. So there's an AED in the room. In the meantime, it activates the crew who's in Port Augusta to come out to you. So he's saying that this is as good a clinic as you probably get in a modern city. So you get teleconference. So this cost us around 1.2 million Australian dollars just for the build of the building. There was not does not include the equipment inside and the land that it's sitting on. So the land was a grant to the Royal Adelaide, Royal Flying Doctors. So everyone in the rural communities know that the value of RFDS. Okay, it's a first of kind in Australia, and we believe it's a first of kind in its world. Okay. So I think I'll end it at that because it's a lot of people talking. This is our view of our operation center. So why won't it stop on it? But that's what our operations center looks like, where we get our calls and coordinate our work. That's our PC24, sorry, PC12. Yeah, it's just about a lot of more people talking. Okay.
All right. Us and providing us with some insight into the Outback medicine in Australia. Now we'll move on to our Q&A sessions. Is Dr. Naim and Dr. Mulyo is here?
Yeah, I'm here.
All right, Dr. Mulyo, there's a couple of questions here.
Yeah. The first question is how much sleep can be safely infused on certain case or heat exhaustion or heat stroke with consideration of multiple electrolyte imbalance, hyponatremia, and does
could fit to do more benefit than harm in accurate cooling method on site. I think the fluid challenge I give we giving every 200 cc is safer than we firstly to give the first time to 1 liter, and then we continue to buy another fluid challenge, and we can do see the vital sign like the fluid output, and then we can give the observation description. After we reach on hospital, we can request the electrolyte diagnosis for the exact dose to give the natrium chloride 3%. And then the two question.
The second question
For
from
second question, for heat stroke, Heckhausen is balance fluid better than colloid in hydration patient. Regarding to my experience in Army in field task, using balance fluid solution is much better than the colloid. It because in the Army setting, in the fluid loss for electrolyte, loss is happening very fast and or acute, so that we give the balance solution is much better. However, the ice pool therapy is so help to lowering patient body temperature. And then the cool balance solution is favorite.
All right. So there's another question from Dr. Siti asking, is there any, do you use cool fluid for management of heat stroke?
Better?
Cool fluids.
The cool balance solution is preferred. I think there's we give the cool balance solution. It's not to give the warm solution. This make the better to give the cool balance solution.
All right. Okay, Dr. Mulyo, there's another question here asking, are there any role of dantrolene for the heat stroke, especially in case of non-responsive to conventional treatment?
The key point is we observation this patient, and we look the vital sign like the fluid output. If we want to continue to give the fluid challenge, so we're not too aggressive to give the fluid challenge, like to give the fastly 1 liter. We just to give the fluid challenge, keeping every 200 cc only, and then we observation for the vital sign, and we observation for the fluid output. So, and if this patient is to reach hospital, we can to give the electrolyte diagnosis for the exact the dose we want to give to resuscitation.
Okay. Yeah, I think the next question from Dr. Naeem. Yeah, there's a question from Dr. Fisha. She's asking, what's the difference between wilderness medicine and pre-hospital care?
Right. Can you hear my voice loud and clear?
Yep.
Basically, wilderness medicine is a subset of pre-hospital care, because when you're talking about the care, you have the intra-hospital, pre-hospital care. But I think, of course, there's a different thing depending on the systems at each country. Like in Malaysia, most of the cases outside of the hospital being managed by the pre-hospital care teams. But under the established divisions of the a subspecialty of critical care teams, they do also have a team dealing with the wilderness medicines. But I think the focus of their team right now is more towards the urban care settings. And as for us, wilderness medicine SID, we are more focusing on situation which is beyond the reach of the normal urban care setting. For example, like in the wilderness medicine, you are dealing more with a situation what we call as chronofield care, while waiting for the help to arrive at the moment. For example, that you are stuck in the jungles for a few days because you cannot get out from the thing. So while waiting for the EMS, urban EMS to come, or you need to plan your evacuation by yourself to the hospital. So it's kind of like have similarities, and it of course has a lot of overlap in things. But the way that I look at it is that for the modern hospital care, they have a lot of gadgets. They bring along the extensive equipment with them. But for the wilderness setting, we are dealing with more with the improvised things, planning for evacuations, and preparing that the evacuation is not possible in the due times. So I hope that answers the question.
Okay. Okay, there's another question from Dr. Devon. I think what she's trying to ask is what's the difference between a needle decompression in versus a finger thoracotomy?
Right. Needle decompression is basically you do the last guidelines basically that you poke the needle at the second in the costal space. But in the latest guidelines, it still recommend that needle decompression be done in the safety triangles. But the problem with the needle decompression, sometimes the needle is too small and it gets blocked easily. And to drain, especially for the blood through a needle, usually it's not very effective. So finger tracheostomy is basically it's just a process, something similar like where you are trying to do the chest tube. You just need to make some incision and use the finger to dissect until you reach the pleural cavities. So basically, you are creating the open hole there so that it is much more easier to drain things. Then, of course, after that, you need to do your vented chest seal on top of that wound that you created.
Um, if I can answer that question as well, we still teach the needle thoracostomy here in Australia. However, the move is to go towards the finger thoracostomy. One of the main reasons is change in body habitus over time. So as mentioned, the needle is small. Sometimes also needle is short. So what happens is that it doesn't actually make it into the chest, into the thoracic cavity because of the fat layer that has to be gone through it. You can even get actually big muscled people that it might not be able to go through. The other problem is that for most of the studies done, you need to be pushing the needle into the chest. As soon as you release pressure on the chest, the needle actually migrates out so that it becomes ineffective after that. So particularly if you're dealing with a wilderness or pre-hospital care setting that is prolonged transport time, you may need to re-needle and re-needle and re-needle. Whereas if you have a finger thoracostomy, it's a big hole that you can shove your finger back in, and it's less likely, not it still can close off, but it's much easier to open up again to decompress.
Yes, I agree with you, Dr. Henry. That's definitely correct.
Okay. Okay, moving on to the next questions. Is regarding on coconut water. So Dr. Chim is asking the composition of the fluid. Is it a crystalloid? Is it a balanced fluid, or is it like a colloid? And do they have any immediate complications such as anaphylaxis? Dr. Naik?
Oh, all right. The question is for me, is it?
Yeah, I think it's from for you, right, Doctor?
All right. Basically, there's only one case report that I'm mentioning the use of intravenous coconut water as a way of giving hydration to a patient with a hypobolic shock. The thing is that in terms of composition, it's much more a little bit. If you look at the content for the electrolyte, it might contain the contamination for the protein, then making it into more of like not really too colloid, but somewhere in between there with the electrolytes and everything. And of course, when you are taking things from the wilderness to infuse into your intravenous, there are a lot of complications that may occur. So far, that to really justify the use is very difficult because we need to understand that sometimes in the wilderness setting, we do not have a large data to say whether that treatment is okay or not. So far, there's only one case report on the use of intravenous coconut water. And if you still have to do it, you still need to have your IV set and everything. So that is why in the wilderness, the best route for you to give fluid is actually via the oral route. And if you cannot get it, you might do other things like subcutaneous or rectal, which is much more easier than the intravenous.
Mm.
I hope that answered the question.
All right. Okay. So for the next question, we have this for Dr. Harry. This question from Dr. Fishak. Can you give any tip or advice when we transfer patient using helicopter or air transport?
There are lots of difficulties, things to consider, rather, not difficulties, things to consider when you're flying by helicopter. So helicopters do not pressurize the cabin. So you have to consider what that means for your patient. Do they have a lung injury or closed bowel loop, for example, wherein change in pressure becomes an issue? One of the problems I've noticed, I don't know whether it's relevant to you guys, but it's you need to maintain. So let's say you have a trauma. I think it was mentioned earlier that you want to maintain you want to prevent hypothermia. So you want to maintain normothermia. Because you're not in a pressurized cabin, it's harder to control the temperature, not just the pressure. So it's not unusual that you're outside and it's very hot, and you suddenly step in and they try to turn on the air conditioner, it's cold, and you step out, it's hot again, or vice versa. It's cold and then they're warming it on the inside and you're hot outside. So it's one of those things that it's uh, the weather is still inside, unlike in an aircraft. The other things to consider is vibration. So there's lots of vibration and noise in the helicopter. It's hard to it's almost impossible to communicate with the patient. So we often use a lot of hand signals. And in fact, we give our patients earmuffs so that they are not bothered by the vibration and noise. So these things that you have to think about. So a lot of the things that we do is prepare everything before we get into the helicopter. Because, for example, do you need any medications? You make communication with your nurse or paramedic to say, these are what we're going to do if these things happen. So you create a plan A, plan B, plan C before you even get onto the aircraft, so that while you're in the aircraft, you can activate all of these things. You have to think ahead about what you're thinking of. I don't know if it makes sense as well, but being in the back of a helicopter is very sexy, as like people like to think, but it's very dangerous. There are lots of risks involved in flying in the helicopter. So it's a lot about your safety, your crew safety, and your patient safety. So all the things you need to be wary about. It's the more you do it, it becomes second nature to you. But if you're just learning it, I think the best advice is to listen, be to those people around you, be cognizant about your environment, because lots of things will happen or can happen if you take your eye off the ball. Yeah, there's a lot to talk about in regard to helicopter transfers. So airplanes are not as hard because, for example, you rarely get on the aircraft with the engine running. Helicopters, we do that every now and then. That adds another layer of safety that you have to consider. At the end of the day, it's relying on the crew that you're with. The pilot is the boss. If they say no, it's no, and that's because it's for the safety of everybody.
Right. Okay. So there's a question of tourniquet. The question from Dr. Kwe. Tourniquet application is generally limited to 2 hours, but wilderness environment often necessitates prolonged use due to extended transport time. So how should you manage the tourniquet in such scenario or in Outback medicine? So should they be released periodically? And how do you mitigate the risk of repercussion injuries? Yeah, this question is open to the floor.
So tourniquets are difficult to use. They have their pros and cons. One of the most important things to remember about using tourniquets is that you actually have to get over arterial pressure, not just putting it on and tightening it, therefore it's working. It needs to go above arterial pressure. Otherwise, you could potentially increase bleeding by preventing venous return without preventing the arterial flow. So those are one of the things. In terms of ischemia in itself, generally, if you've ever worked in theater, particularly with the orthopedic surgeons, they usually do 2 to 3 hours on the tourniquet. So there is room to use tourniquet for that long. It's not uncommon for them to, I mean, having worked as an anesthetist backup for an orthopedic surgeon, is they release the tourniquet for a few minutes, allow blood flow to and from the limb, and then put it back on. So knowing, being cautious, yeah, so being aware of the pressures that you're using, being aware of the time that you're using, whether it's on or off. So these things will be very important. I mean, again, this is different setting. Where in theater, it's a better controlled environment. When you're out in an austere environment, you just really have to trust your equipment. You have to know your equipment, know how it works, and how to be able to put it on and off properly. I'm hoping I answered the question.
Right.
Dr. Naim?
If I can add some of the things, all right. So the recommendation is that when the journey from the wilderness to the hospital is within 2 hours, so basically you do not need to take out the tourniquet, just leave it there. But most of the time in the wilderness setting, the journey much more prolonged compared to that. So that is why for the wilderness first aider, we teach them about the use of tourniquet conversion. So meaning that after you put the tourniquet and you have already settled the assessing your patient, then you might need to re-look into the wound and see whether you still need to put the tourniquet on or not. The thing is that the tourniquet conversion is depends on the level of specialty. Like for those who are trained paramedic and doctor above, they might be able to do it, but this might be difficult for the layperson. So the thing is that for a trained personnel, so every hour they can actually secure the bandaging around the wound, and every hour they will try to look up the tourniquet and see whether the wound is being controlled or not. So if the wound are being controlled, then they will convert, meaning that you remove the tourniquet. But for the non-trained paramedics, our recommendation is just to leave there. And basically, if the tourniquet is already there for 6 hours, do not ever try to lose up the tourniquet in the wilderness, because it increases the chances of the injuries, the release of potassium, and so on. And based on a very limited case report, there has been one case report that documented that a patient was put on tourniquet for 16 hours, and still the limbs are still survivable and not much of neurological difficulty. Right.
Okay. Okay. So going to the next questions. Dr. Henry, is there any difficulty in handling patients from different cultural background? For example, people from Ab Aboriginal and Torres Strait Islander people in the outbreak?
Um, Lots. I think we know this from just working in our local communities. People have their own beliefs and idiosyncrasies. One of them that each they like to be called nations here. So each nation or people is has a different cultural background. So one of them that I encountered, for example, was that um, if the patient died in my presence, I took their soul. I killed them. I took their soul, and I'm now it's now on me. Okay, my fault. And the way to get around that is to have the elder in the room when this patient passes. So there are lots of rituals that you have to go through to do those things. So that's an extreme example. A more common example is more related to the male-female divide. Um, so I was in a scenario where the patient was drunk, he hit his head, GCS 13. We were called because obviously he needed imaging, we needed to be transported, etc. When we got there, there were three females and a male that were in the room that were attending to him. And as soon as we came, they started to move further and further away from the patient, leaving the care to us. And suddenly he needed to take a wee. He needed to void, and as soon as he said he needed to void, all four of them left. And we go, why? Oh, because it's men's business. And then I said, wait a minute, there's a male. Oh, he's not initiated. So he was an adult that's not initiated. Basically, he hasn't gone to the ritual of being an adult male. So he's not considered an adult male, therefore he cannot be involved in men's business. So that was an eye opener for me that, oh, it doesn't mean because you're male that you can do assisted things with males, but if it has anything to do with your genitals, then that's specific for males or females, as the case may be. There's a lot of these other things. Culturally, they don't like talking directly about themselves. They like to talk around themselves. So it takes a while to get to know them and they like this. I know you because you know my friend. Oh, okay, I'll be your friend because you know my friend kind of scenario. There are a lot of these uh, subtle communication techniques that you have to learn. Things that as emergency physicians, it's hard to do because we like to get to the information immediately and want to get to the bottom of what we're dealing with. Each like I said, each people or nation is different. It's good to know somebody within the community to find out. So there are lots of these. I'm sure you can talk about you have similar encounters with other more local or communities when where you work. I hope that's answers the question, or at least gives examples of the question.
So Dr. Naim, do you have any experience in managing different cultures in Malaysia, like the Orang Aslis and the town people?
Yeah, I think that in some of our expeditions we incorporate a lot of islanders who are from the stateless people and fugitives. The thing is that it depends on the location where they are. So the more remote they are there, so you can see that the differences in culture is more there. So they're kind of particularly afraid if you go wearing a clothes that look like a lead coat or something else. So the approach is always try to blend in with the people there, and it would be very helpful that if you can approach their leaders or the head of the community
because they are usually becoming the middle person that will deal with us. And of course, when we are approaching them, we are not probably like just immediately bring out all the equipment and everything. So some of them will get scared. And even in some of our exhibition, they tend to think that we are the enforcement, so they try to jump, try to run away from the places and everything. But I think that to approach the things, the most important thing for us to do is to learn about the cultural differences and try to get a middle person who are very close to the community as a middle person that will deal with the people and instead of us going directly to them. And of course, there are a lot of sensitive issues, sensitive things that we need to be aware of. That's why that before any expeditions or missions to certain place, it is very important for us to understand about this sensitivity issue with regard to that particular community.
Hey, okay, I hope that answered your question, Dr. Greg. Okay, for the next question, for crocodile bite, which antibiotic do we use? Is it the same for all animal bites? We start them on augmentin itself, or do we need any extra coverage?
Right. So we need to understand that the bacteria in the crocodile is a polymicrobite bacteria. Definitely, it has all the aerobic and anaerobic. But in the context of the Sabah, most of these crocodile, they inhabited the estuarine areas and some of the marine area as well. So it is particularly important for us to use the antibiotic that also cover for the marine infection. And some of the bacteria are quite nasty, so it needs to be directed towards your culture activities. So ideally, you need to start the broad spectrum antibiotic. And if the crocodile attack occur at the estuarine or the marine area, so you should add on something to cover for the marine infection as well. And after that, it should be tally according to the tissue culture activity.
So we have our last question on insect bite or stings, particularly when this one is directed to Dr. Naim. What are the essential considerations for management of insect stings, particularly in cases where the insect type is unknown and the victim exhibit symptoms such as muscle twitching? Would you recommend immediate transport to the nearest medical facilities under such circumstances?
Right. We need to understand that insect stings is a quite special. Most of the time, we are unable to identify what are the insects that bite or sting the patient. But the common one would always be your Hymenoptera group, either a bee, a wasp, or even the ant sting. But of course, there are certain cases you have a sting that can cause a neurological manifestation, everything, like spiders, everything. But the good thing is that most of those things are not very common in the wilderness setting. So the thing that you particularly need to look for is to see whether there is any critical organ involvement involved with the patient. For example, like if the patient start developing anaphylaxis or anaphylactic shock, definitely after you administer adrenaline, you need to bring out the patient because you are worried about the secondary phase of the anaphylaxis or even refractory anaphylaxis. But if the symptom is very mild and after your assessment there is no ongoing threat with the critical organ system, then you really need to balance carefully between the benefit and the risk of bringing back the patient to the hospital. Because we need to understand that when you are in the wilderness, you need to take care of the logistics, you need to take care of the cost and also the expedition itself. So by the time that you need to evacuate the patient, you will definitely will be lacking of people to stay at the base. So there's no fast and hard rule for this situation. So for me, I will always prioritize evacuation will go if critical organ system involved during the incident.
All right. So do we have any more questions from the floors? We still have 50 minutes left.
There's a question here about telecommunication in the outback or in the remote areas.
Yep.
So in Australia, we tried. It's basically mobile phones. Probably is the simplest one to use. Secondarily, would probably be when there are problems with that, and it's usually because it's choppy. Then we use landlines if they're available. Most clinics will have them. But then we use all types of telecommunication, ranging from email to fax machines to email to MMS app type stuff. In really remote areas, we carry satellite phones. But even satellite phones are very choppy and difficult to use. And I think most importantly, they're very expensive to use. So their bang for buck is actually very poor, but when push comes to shove, you need to use it. Yeah. But for most part, it's still cell phone. SMS is also very good. Although they don't recommend using your phone in flight, we are able to use and send SMS very often better than, because all you need is one bar. You have one bar of signal, you're able to send a message in most cases. So yeah, we use all types, whatever is available. I hope I answered that question.
Do we have any more questions for the speakers?
May I ask a question?
Yes, Prof. Got it.
Yes. Sorry about that. Just want to ask. I think Dr. Limgenco had touched a bit about the situation where there are some limitations to Outback and remote area in terms of. I mean, I think Dr. Naim also had talked about limitations of certain so-called life-saving drugs and so on to be given. And I've already, know that there are certain drugs stored in the safety box. But for example, because I'm in the issues of snake bite envenoming, and I think Australia also had the same kind of predicament in remote areas. Do we have kind of a protocol or regulations or maybe guidelines on, for example, how antivenoms can be administered in remote areas, either remote clinics or in terms of rescue operation? Do we bring antivenoms along? And if so, how should it be, and who is allowed to administer, or do we have a advance directive, either written or direct, for such situations? Maybe can we have our panelists to comment, and also maybe in terms of, like, for example, in the army situation, I know travels as well. So how do that applies, for example, in Indonesia? So can we have our panelists to comment about that? Thank you.
If I may start, like I mentioned, we don't keep antivenoms and other such drugs with us. They're difficult to store, they're expensive, and I think most importantly is that if they're given incorrectly, can cause more harm than good. So for most parts, we would like to determine whether they are truly, one, envenomated, and two, by what type of snake, if possible. Now, sometimes that's not possible, and we end up giving them polyvalent antivenin. And again, that has its own problems. I think Prof. Khaldun is aware that although in Australia we have type-specific antivenins, they're inoculated into the same set of horses. So the chance that you actually get a polyvalent drug, polyvalent antivenin, is very high. In terms of transporting, so I think the big question is how long does the patient get to an area where we can then transport them out following the snake bite. That is probably the bigger determinant than us getting to the patient with antivenin. It would be nice to know whether they are truly envenomated and by what kind, but that's often best done at a tertiary center. It will be guided by an expert who will then say risk benefit says we will end up giving them the polyvalent. So what we will do then, we will take the antivenin with us to go to the patient and give it to them. That's the best case scenario that I can think of. There are no real protocols to say how we're going to do it otherwise, because we usually do it based on knowing what we're highly suspicious of. So other things that we go on are geographics. So what are the snakes in that area that might guide us? But otherwise, if in doubt, then just give polyvalent. Doctor name?
Antivenoms are not routinely being carried during the expeditions or in the wilderness. But we just need to understand that each mission to the wilderness is different. Sometimes just involve one or two people, but sometimes it is a very well planned expedition that you are able to set up your medical base, or even like expedition to the certain place using the big sheet. They actually even have a treatment area like a small hospital in the ship itself. So it should be we cannot make a fast and hard rule on what whether we can carry or not. It's rather to look at the logistics and the purpose of the expedition itself. And we have this common issue also in Malaysia, for example, regarding the layperson administering the adrenaline for the anaphylaxis. So far, the general consensus that for all the treatments involving the injection, it should be done by the medical personnel, right? But if you look at the concept like giving the adrenaline, it's just similar like someone giving the insulin to people who need this situation. The best way of dealing with this thing is to establish a specific protocol be used, whether it is online protocol or offline protocol. And the best thing is that for the person to administer, it must be fairly according to the level of practice.
I think Dr. Naim has disconnected. Dr. Mulyo, do you have any input on the matter?
Maybe a comment from our colleague from Indonesia. How about in the army? How do they deal with, the army travels longer in remote areas, for example, in the medics? Is it included, antivenoms in the medics' care for such expedition, for example?
About antivenom or about the animal
I mean, antivenom is an example, but what kind of, the restricted drugs? But do you carry antivenoms with you for expeditions in remote areas for the army, for example, in
Indonesia, it's not like to another country. Another country with antivenom, another country have monovalent, but in Indonesia we have a polyvalent antivenom, like we call the sabu. It's for to snake bite. For to the sea bite, animal sea bite, we don't have antivenom for that. Actually, usually in Navy, the case of the animal bites is like the jellyfish, maybe about the crocodile animal bite. I don't have meat when I was in Chute. Thank you.
Okay, thank you, Dr. Mulyo. Dr. Naim, would you like to continue?
Yeah, sorry for that. So I think it must be given according to the level of expertise. Even for ourselves, like medication for painkillers and everything, first aider and normal first aider, they are only allowed to give over-the-counter medications like paracetamol, ibuprofen. But for a trained physician, they are allowed to give the opioid and even perform the regional anesthesia in the wilderness. So it must be tailored to the level of expertise. And then number two, it must follow a specific wilderness protocol. And this protocol also should be established in condition like if you are able to consult the wilderness physician via a medicine or by the phone, then you should consult them first. But if it is not possible, then you should have the offline protocol of what you should be able to do or not.
Aduh.
Sorry for the line interruption. So that would be the my comment on this.
Thank you, Dr. Naim. So, any final sharing from the speakers? Dr. Henry?
No, good. Thank you. But yes, this has been very educational for me. Thank you very much.
Thank you. Okay, so I think we'll conclude today's question and answer sessions. And once again, thank you so much for engaging and informative sessions, Dr. Naim, Dr. Mulyo, and Dr. Henry. I believe we have all gained a lot of knowledge from this session, and your expertise and knowledge have made this event truly special. Once again, thank you so much for joining us today. And we will move on to our Kahoot session next. So I'll be sharing the link through the screen, so you guys can join the link and stand a chance to win some amazing prizes. All right, so you can go to the Kahoot website, www.kahoot.it, and put in your game pin 3500917.